So the next talk about the cutaneous lupus and management update by Dr. Huda Al Saffar. Dr. Huda is a consultant dermatologist who trained in Canada, and I have to say one of the few dermatologists still very helpful for us, still see connective tissue diseases patients because a lot of dermatologists don't see these patients anymore. So hopefully give us an update about the presentation and management of cutaneous lupus. Dr. Huda.
So we'll talk about cutaneous lupus. I think most of you see manifestations of lupus every day because you see patients more than us and you manage those patients more than us. Okay, so it will be a quick presentation, easy one. So this man is a British singer. His name is Seal. He has facial chronic cutaneous lupus, and this type is a discoid lupus erythematosus. You can see his face has many scars. It's disfiguring, so that's why we use this singer as an icon of DLE, and we can use that in awareness. So I'm gonna show you some celebrities that has lupus. I think maybe most of you know them. Toni Braxton, she's American black singer. Also, she was hospitalized for pericarditis and she was diagnosed of lupus. And now she's a figure for lupus, and she's participating in awareness of lupus. Well, Bush's dog has systemic lupus. That's just to show you that it can affect animals too. Lady Gaga has positive serological test for lupus, but I'm not sure if she has systemic lupus yet or no, I'm not sure. So we treat cutaneous lupus because we want to reduce the disease activity, we want to increase quality of life, and want to minimize cosmetic damage, as you see the singer Seal. So we have classification. We have Gilliam classification. It's LE specific, lupus erythematosus specific, and non-specific. The specific one, we have acute, subacute, and chronic. There is a strong association with acute cutaneous lupus with systemic lupus. Whenever you see the malar rash or the macular papular rash all over the body, that can be, very positive with the activity of the systemic lupus. But subacute cutaneous lupus, they have only 15% of those cases have systemic lupus, and 5% of chronic cutaneous lupus. And we have many types of chronic cutaneous lupus, and we diagnose it either clinically and also with the pathology. And only 5% of those people will have systemic lupus. But we have to monitor those patients in the future because they might get systemic lupus. So here, I think the acute is more with systemic, subacute is less, and the least one is the chronic cutaneous lupus. So this is the Gilliam or Gilliam classification. We have lots of LE non-specific. Everything actually in dermatology can be. I will share with you some cases later. But maybe I had one patient from Dr. Aqil, I think. She has systemic lupus and she had hair loss. When I examined her, she has non-scarring hair loss. So we have three things can happen with that patient. She might have lupus hair, she might have telogen effluvium, and she might have alopecia areata. So we can do a biopsy. It will show telogen effluvium. It will show if it's alopecia areata. But lupus hair, if it's discoid, it will show, but not lupus hair. Lupus hair is non-scarring. So I will show you some pictures of acute, subacute, and chronic. I think most of you see this acute cutaneous lupus because most of them comes to you for treatment. When we see this, we tend to think of seborrheic dermatitis, we tend to think of rosacea, we tend to think of lupus, and also psoriasis, okay? But it depends on the history and also on biopsies if we decided to do. So this is called malar rash or butterfly rash. It's photosensitive erythema associated with exacerbation of systemic lupus, and it heals without scarring. Treatment, you have to encourage your patients about behavioral changes. Always seek the shade, avoid exposed sunny areas, wear protective clothing, apply sunscreen every 2 hours. We can use topical treatment, including potent topical steroid, immunomodulators, and I will mention those names for you later so you can use them. We can do PDL laser. It will help the erythema for those patients. And there's a common question from the rheumatologist saying, this patient has photosensitivity, so how come you're going to use PDL, which is pulse dye laser? It's a kind of light, so it might exacerbate the look of or the malar erythema. But this is not the case because the pulse dye laser is not UVA and it's not UVB, okay? And also controlling the lupus, the systemic lupus, can help the acute cutaneous lupus. You can see this is type of annular. Annular, we have two forms. We have subacute cutaneous lupus, we have two forms. We have annular, which is this one, and we have another one, it's called papulosquamous. Papulosquamous, it's plaque with scale. Anything that looks like psoriasis, we call it papulosquamous. And one of the variants of the lupus, it's papulosquamous subacute cutaneous lupus. And we diagnose it based on biopsy. But we cannot say this is subacute cutaneous lupus. It's one of the differential. We have to do biopsy when we see this. So 50% of subacute cutaneous lupus have 4 diagnostic features of systemic lupus. 70% will be positive for anti-Ro. And you know, those patients tend to have neonatal lupus in their kids. So we always tell them if they get pregnant to go to high-risk pregnancy. A chronic cutaneous lupus, we have lots of things, including discoid, as you see in seal, chilblains lupus, lupus paniculatus, lupus profundus, tumid lupus. You know those? Okay. Yeah. Okay. A classic discoid, you know the discoid, right? Okay. I will show you a picture of chilblains too. LE paniculatus. When you see, sometimes you see atrophy on the thighs and buttocks with or without inflammation. Lupus paniculatus tend to be very hard. It's like morphea. When you see morphea, it's exactly. And we have to diagnose it with a biopsy. So it's the inflammation of the subcutaneous fat. Sometimes there's an overlap, paniculatus, and on top of it, discoid lupus. So that's lupus profundus, okay? Tumid lupus, it's urticarial, it's not urticaria, urticarial erythematous papules, nodules. When we do a biopsy, we see superficial and deep perivascular lymphocytic cell infiltrate, but we don't see much of epidermal change, sometimes a vacuolar change. And maybe you heard about Jesner's. Do you know Jesner's? Okay, okay. So forget about it. It's a biopsy. The Jesner's is exactly like tumid lupus. Tumid lupus, like erythematous nodules on the face, on the chest, on the back. The difference is we have to do a biopsy. And when there's epidermal change, it's more with tumid lupus. When there's no epidermal change, it's just Jesner's, and Jesner's is non-specific, but tumid lupus is more specific with systemic lupus. It's like the LE-specific lesions. And there is another variant. It's lupus lichen planus, like lichenoid lupus. We tend to do biopsy to diagnose that. There's mucosal and there's hypertrophic one too. So this is a picture of discoid lupus. It's atrophy. There's atrophic plaques, okay, and you can see there's it's violaceous, brownish with the scarring in the middle. You cannot see the carpet tack scale or the follicular plugging here. I will show another picture of follicular plugging. You know follicular plugging? I'll show you. This patient, you can see, has those erythematous painful nodules. And those patients tend to have it maybe in the winter. We see this a lot. There's two things can be. There's something called chilblains, and there's something called chilblains lupus. We cannot differentiate. We have to do biopsy. The biopsy will show typical lupus, typical typical chronic cutaneous lupus. Epidermal change, mucin stain positive, and superficial and deep perivascular lymphocytic infiltrate. But the chilblains, the regular one, that there's some patients, they will get it only on damp, cold weather. That's not lupus. So we tend to do biopsy. You see this? Maybe, I think one of the rheumatologists sent me one, yeah. So in discoid lupus, you tend to see, this is a scalp, okay? This is a scarring alopecia. They always come with the scarring alopecia because there's a lot of inflammation. And when you have inflammation, they will have fibrosis, okay? So they tend to lose the hair follicles. But you can see the follicular plugging, like follicle that's plugged, okay? That's, when we see this, we think of discoid lupus. And we call it carpet tack scale, if you heard about that. This is the carpet tack, so just showing you. I think you will, when you read about that, you will, lots of explanation. They use this carpet tack scale a lot on follicular plugging. We have to do biopsy for those patients to see the activity of the disease and to diagnose, because there are some other cases that resemble discoid lupus in the scalp, like lichen planus. So treatment, behavioral. Smoking, you know, smoking has the aromatic amine can induce lupus, and also when you use antimalarial, it will be not that effective. So you have to encourage your patients to quit smoking. Avoid sunbathing, avoid tanning salons, avoid traveling to regions near equator, avoid outdoor jobs. Sometimes you have to have committees for those patients to reduce their activity in the outdoor. And also, you have to give vitamin D, because if you give that much of sun avoidance, they will tend to have deficiency of vitamin D. So you have to be very strict about behavioral. There's clothing that actually we prescribe in Canada from a brand called Sunveil. It will provide some SPF, a good SPF actually. There are hats, swimming suits, everything. They have nice things. So we tend to encourage our patients. And always tell your patient to use sunscreen. So sunscreen is the last thing to do. But first is the behavior, okay? So not the first thing is sunscreen. Sunscreen, we tend to have physical sunscreen and chemical sunscreen. The physical sunscreen is like these zinc oxide or the pseudo-cream you use for your kids. You know pseudo-cream? Zinc oxide, butt paste, anything, okay? This is a zinc oxide, and it tends to reflect the sun. It's like as if you're wearing clothes, okay? But it's very white. So in our skin type, it's not good. Sometimes they add color to it to fade the white color. And there's chemical sunscreen, so it just now you have to look for broad spectrum, UVA, UVB protection, SPF 30 and more. Don't get fooled by the 100 but you can use it, it's okay. It's the same as SPF 30, 50, it's just minor differences, okay? And I tend to do photo testing for my patients for UVA and UVB, just because I will order some screens for their cars, because UVA can penetrate through a window, but UVB will not penetrate. So if they have UVA positive, I will tend to encourage them to have a screen in their cars, okay? And we do that in Sabah Hospital. So we tend to use topical steroid, very potent topical steroid is better than low potent. Sometimes we do intralesional triamcinolone, especially in lupus profundus, lupus panniculitis, discoid lupus, hypertrophic variant too. We can do that. There's calcineurin inhibitors, tacrolimus, pimecrolimus, if you know. There's a protopic Elidel. Have you heard about that? We use those. Those are steroid-sparing agents. It acts like a cyclosporin, but topical. So they compared it actually with potent steroid, and it shows there is no difference. The topical steroid, it's better to reduce the hypertrophic one, okay? But this one, it will not give you much of the telangiectasia after, the complications of topical steroid, because they will, after prolonged use of topical steroids, they will have telangiectasia, and then you have to do PDL laser to get rid of that. There's another one, it's called salbutamol. Salbutamol, we use it for asthma, and now it's in a cream. It's not available in Kuwait yet. It's beta-2 adrenergic receptor agonist, and will activate the receptor on the CD4 cells, and this will inhibit the interleukin-2 and interferon gamma, so will reduce the inflammation. So that's another alternative to use. So we have a couple of things. We can use acitretin. It's a systemic retinoids. It showed the good results similar to hydroxychloroquine, because we use hydroxychloroquine. And it's very good for hypertrophic lesions. We use this for psoriasis too, acitretin, okay? We can use antimalarial, methotrexate, mycophenolate mofetil, azathioprine, IVIG, and rituximab for very recalcitrant cases. That's it. Any questions? Yes.
Laser hair removal treatment.
Yes.
This is the most common question from my lupus patients.
Yes.
Is it safe?
Yes. Yes. It's safe. Yes.
I don't have experience with that, but I know that there are different types of machines or different types of laser treatment. Are they all safe?
There is Nd:YAG laser. Nd:YAG is not it's not a light, okay? It's a laser, and it's not UVA and it's not UVB. There is intense pulse light. I encourage them to avoid intense pulse light, IPL laser. It's better to use Nd:YAG laser.
What is the abbreviation for
IPL.
no, the
NDIAG, it's just NDIAG. NDIAG, it has many brands.
Okay, so which one is the most used?
NDIAG. IPL is good for white complexion. It can give hypopigmentation in my skin color, let's say. Okay, so it's better to use NDIAG.
Why would you advise them to avoid? Why would you advise your patients to avoid this particular kind of?
Why? IPL because no, IPL because it's a light. It's better to use NDIAG. Just use NDIAG because our skin type is not even suitable for IPL.